Hi, my name is Miriam Rafferty, and today I'll be presenting about sustainment and sustainability assessments, providing a case in early Parkinson's disease. I'll begin by just introducing the initial implementation project, although I'm going to skip through that fairly quickly because I want to then get to focus on what we've done here with our project for sustainability and sustainment. And I'd like to share and identify and contrast tools that support sustainability. For my initial project, we wanted to look at best practices in Parkinson's disease, and best practices in Parkinson's disease emphasize early rehabilitation specifically for exercise prescription. So we did publish this case in 2019, and this case is describing our first year of implementing a proactive physical therapy program for people with early Parkinson's disease. We reported it and disseminated it as a case report because it's not a randomized controlled trial. This is really an administrative or operational change that our organization made. And we made that change using implementation frameworks, many of which are available kind of in other LeaRRn archived presentations. And I'll share some more about those at the end of this talk. But we use the knowledge to action cycle, which hopefully you are familiar with. And we kind of went around that once. What we found was that consultative physical therapy or proactive physical therapy helped people with early Parkinson's disease to increase their time spent exercising, as well as the number of individuals reporting different types of exercise. So you see here that this is just self-report. 50% of the people that participated in the program reported that they were doing more exercise a year later than they had been doing before their consultative physical therapy evaluation. And then in black, you see that the number of people who did aerobic exercise, the number of people who were doing strength and balance and flexibility exercise all increased after the consultative PT program. And what's interesting is this is a PT program in the real world. It's real billable therapy. We're trying to help people meet the strength training guidelines or the aerobic training guidelines, but we weren't working out with those people 3 or 4 days a week the way that you would need to meet those programs in physical therapy. So our data showed it worked, and our organization wanted us to keep it going. Our patients wanted us to keep it going. Our referral sources wanted us to keep it going. So then we started looking into what is the implementation literature on sustainment. And we realized sustainment is really a process. It's not just like in traditional research, it's this end of a study. Let's just keep it going. Let's see if it keeps going without us. We know that that's not really realistic in the real world. So when we started looking into the definitions around sustainment, we found first the definition of maintenance, which is used in the LeaRRng framework, which is an implementation evaluation framework. And maintenance is the extent to which a program is maintained or continued over time. This could be at the individual level. So if an individual was participating in a randomized controlled trial and they were doing it twice a week, did they keep doing it twice a week after the randomized controlled trial ended? It could also be at the program level, that if a gym was hosting an exercise class twice a week as a part of a study, or they had the grant funding, would that program continue after the study ends? Does it have the funding? How is it being maintained? And what we know is that it's best if you can institutionalize this program or practice. So it's really like, this is just what this gym does. Then it's policy, it's there, it's routine, and it's likely to be maintained. But this is possibly a static process that it's maintained as is, status quo. Sustainment is at the other end of this, kind of a further down that spectrum, where now instead of just being, is this maintained for 6 months or a year, we're looking at true sustainment to be a period of time, typically at least 2 years before you would say something is sustained, and that the program, the intervention, or individual behavior change is maintained, but for this longer 2-year time period. And definitions of sustainment include this opinion that they're going to evolve or adapt. In order for anything to sustain for 2 years, you're going to have to change. And one of the things we learned over the many years that this program has been going is that, we had to figure out how to sustain through a pandemic, how to sustain through a big organizational change where we moved into a new hospital building. There's a lot of change that you have to evolve and adapt to. And that while it's evolving or adapting, you need to be able to continue to show that it's producing benefits for the individuals or the system of care. In between these two concepts of maintenance, of a static short-term thing, to sustainment, is the concept of sustainability. And that end of the word is really important, that it's the ability for something to sustain. And Because of that, you can measure it earlier. It's a property of the intervention itself. And if an intervention is deemed and like people say like, oh yeah, we could sustain this, then chances are it could be sustained. When you describe a program to clinicians and they say, there's no way we could keep doing this without funding, well, then that property of the intervention makes it unlikely to sustain. And so sustainability is something that you can start assessing very early in the development of an intervention or the development of a clinical program or community program. So we're really kind of focusing on this concept of sustainability and sustainment. So next I'll explain about sustainment as a process. And the knowledge to action cycle that I'm showing here is a process model that's frequently used in rehabilitation research. And you can see that sustaining knowledge use is this process down in the bottom right-hand corner of the cycle. But how are we going to think about it throughout? First, I'll say we need to recognize that implementation science starts in the center funnel. And in rehabilitation research, a lot of the work that we're doing is still in this knowledge inquiry phase. We're still asking questions about what is the best evidence and the best thing to implement. Knowledge synthesis is where we start to synthesize the evidence into meta-analyses, systematic reviews, and we can create products like clinical practice guidelines. Once you have a clinical practice guideline, then you can kind of follow this process model, this cycle around. There's a lot of different implementation science models, though, that help support the process. So we can look at the barriers and facilitators, assess kind of what is the local need to change this intervention to be able to implement it. How are we going to adapt it? And what implementation strategies are we going to use? And these questions on the left side of the cycle can be supported by using the consolidated framework for implementation research. We then can use the expert recommendations for implementing change, or the C4ERIC matching tool, to help match barriers to one or more of the 73 categories. And then on the evaluation side, we can use something like the LeaRRn framework, which I mentioned earlier has maintenance as a component. And you can just repeat LeaRRn as you go through time to show that you've maintained your program. Sustainability in the initial knowledge to action cycle really lives here in the bottom right-hand corner. And I'll talk to you a little bit today about the NHS sustainability model and the clinical sustainability assessment tool. However, I want to highlight how important it is to consider adaptable and sustainable strategies early. There's something called the dynamic sustainability framework that really brings that in earlier. And so I just want to highlight kind of the complexity of all of these implementation resources, and the LeaRRn archives include a lot of presentations that talk about each of these stages of research. So from here on out, I'm really going to be focusing on the purple on this slide and the sustainability and sustainment tools. So just highlighting some of the tools that you could use to measure sustainment as your project goes through the sustainment phase, as well as sustainability assessment tools. We have the LeaRRn, which I mentioned earlier. The LeaRRn is a really accessible and well-described and frequently used implementation evaluation framework. It has reach, effectiveness, adoption, and implementation, which I kind of like to think of as implementation fidelity of your evidence-based intervention. And all of these things can be measured once, but they can be measured multiple times. So what the maintenance part of LeaRRn is really just keep measuring it. Look at the proportion and representative of the patients you reach and the settings and staff that adopt your intervention. And then do that at baseline, do it at 6 months, do it at 9 months, do it at 12 months, and start to look at, if you see reach changing over time, why is it changing? Are you purposely continuing to try to improve the representativeness of your sample, or are you losing people over time? And if so, what are the characteristics of the people that you're losing? So it's really just highlights how important it is to use these metrics over time. You can continue to measure the effectiveness for your patients or your organization. You can look at implementation fidelity over time. Sometimes people will make something called a control chart, where they measure, like, each month they'll do an audit and see whether the intervention or the outcome measure is still being done. And then from a maintenance standpoint, it's, are you maintaining the organizational or community capacity and infrastructure for the evidence-based intervention? And how are you evolving it as you go? And that's evolvability, and documenting your adaptations is really important as well. This is now getting into sustainability assessment. This is the NHS sustainability model is the national health system in the UK. And they have this really nice descriptive report of sustainability, and they developed a tool. One of the downsides is that the scoring of this tool is a little bit strange, but one of the upsides I'll say is that it's really helpful too. It gives you like the categories that you're scoring on are really helpful. So it splits 3 domains of staff, process, and organization. And then it has 10 kind of constructs around that, each of which kind of has a multiple choice question to help you kind of see whether you're high or low on that particular item. One of the downsides is that this kind of really large report isn't in the traditional peer-reviewed literature, and so it hasn't been used as much as I think it could be. And it's a little bit difficult to understand. The clinical sustainability assessment tool was developed by a group of researchers at Washington University in St. Louis, and they have a clinical sustainability assessment tool as well as a program sustainability assessment tool if you're working more in a community program as opposed to a clinical setting. And so the clinical sustainability assessment tool, I think, has similar 7 kind of constructs instead of 10. And what's interesting is that these kind of align into the same domains. You can kind of separate them out into being about the people who are involved, the processes involved in your project, as well as the organization itself. For us, and what we did as a team is we decided we wanted to measure the sustainment of our early Parkinson's program and how did it sustain over time. So we basically repeated some of our reach and our effectiveness measures that we had done initially. And so comparing to those initial numbers that you saw here in the light gray, we have the number of people who reported more exercise, and we have 70% here, and then 64% in year 3. These data are a little bit different than I showed in the earlier slide because I actually used a different denominator. Based on the data that was available in 2018. We had less, because we hadn't set out to measure it, we were doing less interviews and surveys with people. Over time, we looked at our program reach each year, and what you see in the green line is the number of patients, the number of unique patients that were evaluated in our proactive physical therapy program. So over time, we increased from 28 patients to 110 patients. So it's a really nice increase in reach. We were looking at whether patients were coming back for repeated visits. And what you see is that by year 4, 25% of those 110 patients were repeat visits. So we actually saw that as being a potential opportunity for improvement because we thought a lot of these patients could be seen maybe once a year. And so we've continued to do some outreach to try to make sure that people are doing that dental model of physical therapy where they come back every 6 to 12 months. And so I'll show you kind of a sneak peek of some of our data is that from that 2019 year, again, slightly different metrics, we had about 27% of our patients were repeat patients, 101 unique patients here. I think this excludes people, the 110 included people who came to OT or speech, and this includes just PT. And now going up, we now have over 50% of our patients are repeating. But we still have that number hovering that little bit over 100. And so to me, that lets me know organizationally, we've now done such a great job of retention, but maybe we're losing new referrals to someplace. So we can go, my sustainability brain says, oh, let's go figure out where are those people going. It's kind of interesting. You can see our 2020 COVID dip and then the rebound of people all seeking care now once the world opened back up again. Another measure of sustainment that we have is our repeated re-aim. And so we looked at how many people were referred. And we went from, this is not how many were seen. This is how many were referred by the neurologists. And we had 38 referred in the first year, and that increased to 133 who were referred. So that seems like a really big increase. It is a really big increase, but actually the clinic that was referring to us grew at the same time. So we had to also look at the number of new patients per year that clinic was seeing. And that increased from 150 to about 250 people per year. So while it looks like we quadrupled our referrals, our percent of referrals from the neurologists increased more modestly. And it still gives us some opportunity for improvement. So I'm not going to go through each one of these. They are reported and in Jillian McDonald's paper in Implementation Science Communication. And you can kind of read through that paper to see how we repeated the measurement in 2016, 2018, and 2019. Switching over to sustainability, this is something that we also started measuring kind of in the middle of this project. We did both the NHS sustainability model, and then about a year later, we did the clinical sustainability assessment tool, and we have slightly different samples in these two samples, but I wanted to share our outcomes and what we learned from them. So I have things broken up into the staff, processes, and organizations the same way that I shared before. And what you can see popped out as strengths in the two measures are clinical leadership in staff, and then engaged staff and leadership in the CSAT. So we got a 15 out of 15 here, and we got a 6.5 out of 7 on the CSAT. We also had a very strong fit with the organization and culture using this NHS sustainability model, and our process outcomes and effectiveness was on the strong side for the clinical sustainability assessment tool. But so that's great. We're doing well in a couple things. We also want to look at our opportunities for improvement, which are bolded in black here. And one of the things that's interesting, you can see that the NHS model scoring is really weird. Every construct is scored out of a different denominator. Some of the denominators are things like 11.4, or like I don't know mathematically how they came up with it. But what you see here is that some opportunities for improvement that were caught in the NHS sustainability model are behavior of the staff and like whether or not they're consistent in their behaviors, senior leadership support. Some of our clinicians didn't see the benefits beyond helping patients. So they did see that we were helping patients, but we weren't showing how we were really benefiting the organization. And maybe they didn't also appear to think that we were all that adaptable in what we were doing. They felt like our infrastructure might not be as good or at supporting. And interestingly, a year later, our scores on the CSAT were much better. The lowest score we got there was a 5.7 out of 7, which is like mathematically not that low. So it does make me a little concerned that the CSAT might have a ceiling effect, or, just something to keep in mind, which the developers are aware of. And they actually mention that in their reporting about the measure. So I kind of have to put on a slightly different lens when I'm looking at it. But in the CSAT, we found that monitoring and evaluation, workflow integration, and organizational readiness were our relative weaknesses and things that we could address. So, kind of taking all of this in general, I don't think the year difference between the NHS sustainability and the CSAT, we actually changed that much about the program. We did try to make it more adaptable. We did try to make sure that we were sharing with leadership kind of the benefits of the organization and making sure we had strong organizational buy-in. But I don't know that solved the problem, which it almost looks like it did. We are repeating these scores, which we hope to present this year we will be presenting this year at the American Congress of Rehabilitation Medicine. So it'll be interesting to see how the scores have now changed since we've been more mindful about how we were trying to improve our sustainability. One additional benefit about the NHS sustainability scoring system is that it does give a cutoff, which as a rehabilitation clinician at heart, I love cutoff scores. And their cutoff scores that if anything is greater than a 55, that you should be optimistic for sustainability. And I really like that. They're not guaranteeing sustainability, but we can be optimistic about it with that score. And our average score on the NHS sustainability model was 71. So that is, yay, we can be optimistic. And I think that that's shown by the fact that this model sustained through a pandemic. It's sustaining now 7 years after it was initially created. And we'll hopefully be doing more studies in the future with looking at how we can implement it in other systems of care. So as I mentioned before, the results of that study, if you're interested in more details, were published. Jillian McDonald was a research physical therapist on my team. She's since moved to a new organization, but she helped, and other people on my team helped to create this model to really show how you can repeat the re-aim. That's one of the cogs in your wheel. You need to think about these dynamic sustainability strategies in that sustainability phase or sustainment phase, but also think about those dynamic strategies early when you're developing your implementation strategies. Have sustainability goals early. And then you can use your sustainability assessment tools periodically to see how you're doing. So these are all cogs in your wheel that can help your knowledge to actual action cycle, I think, be more effective and more sustainable if you think about sustainability early. So some other resources are linked in the slides. I have links to the initial and the sustainment publications. which, again, if you're in the field of Parkinson's disease or neurologic rehabilitation and how to implement and sustain these more consultative health promotion and wellness focused implementation interventions, those are useful. They may also be useful as just like a template for how you could publish or disseminate some of your work. Some of the frameworks that I talked about, and I really didn't introduce much, I kind of jumped in, but if you want to go back and look at them, the REAIM model, the NHS sustainability model, the clinical sustainability assessment tool, and the dynamic sustainability framework are linked here. And then I also want to share just some newer resources, because actually a lot has changed since we started this program in the field of implementation science. The Consolidated Framework for Implementation Research, or now has a 2.0 version. We use the initial version, and Laura Damschroeder did do a LeaRRn talk in the archives, I think back in 2021, where she introduces this revision to the CFR guidelines, and the new CFR tool, I think, could be really helpful. Also, there's now some more attention in the field as a whole to looking at implementation strategies specifically for sustainment, not just that initial behavior change and initial implementation. So there was an article recently published in Frontiers in Implementation Science, and it would really focus on implementation strategies for sustainment. So I encourage everybody to look those resources up. Finally, I want to acknowledge that all of implementation research is really a team endeavor. It includes a lot of clinicians and clinical management. A lot of thanks really goes out to Jillian McDonald, who's really helped with the dissemination of this work, to PT audiences, as well as my funding, my research mentors, and my lab members. Thank you. And the full resource list is in the slides.